1, 2,
And review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right, like it's math or something.
Yeah, exactly. It's like engineering. You break your arm, the x-ray shows that jagged white line right on the radius, and the doctor just points to the screen and says, well, there it is. It's broken.
It's totally binary. It's clean.
It is. It's comforting because we like things to be visible, but we want to categorize the pathology neatly into a box so we could just fix it. But then you step into the world of obstetrics, specifically the hypertensive disorders of pregnancy, and suddenly that x-ray machine is just broken.
Oh, completely broken.
We're looking at a diagnostic landscape that is, honestly, it's incredibly murky. The symptoms overlap, the timelines blur, and the patient sitting in front of you might be smiling and chatting while her internal organs are actively failing.
Yeah, it is the absolute definition of diagnostic muddy waters. And if you are navigating the labor and delivery floor or, sitting down to take your final nursing boards without a compass, you are going to sink quickly. The stakes are simply too high. We aren't just dealing with one patient here. We are dealing with a maternal fetal dyad. 2 lives tethered together by a vascular bridge that is potentially collapsing.
That is the exact tension we are tackling today. So welcome to the deep dive. We're talking directly to you, the listener, the nursing student, the future elite OB nurse who is staring down one of the most heavily tested, highest stakes areas of obstetrics on your upcoming exams.
Hypertensive disorders of pregnancy.
Exactly. We've taken a massive stack of your source material, clinical guidelines, pathophysiology notes, pharmacology breakdowns, emergency protocols, and our mission today is to decode it all for you. We're going straight into the high-stakes reality of the obstetrics ward.
And as your clinical mentor for this deep dive, I am making you a promise right now. We're going to apply the Pareto principle aggressively today.
Yes, the 20-80 rule.
Exactly. If you've looked at your textbooks, you know there are hundreds of pages, endless charts, and just a dizzying array of lab values on this topic.
It's overwhelming.
It is, but we are going to cut through that noise. I'm going to teach you how to think like a safe, prioritizing OB nurse. We are focusing relentlessly on the 20% of high-yield concepts that are going to yield 80% of your exam points.
Love that.
And honestly, more importantly, 80% of your clinical catch rate when a patient is crashing. We will focus entirely on maternal and fetal safety, how to spot the priority patient before they code, and how to avoid the traps that test writers and the real world just love to set for you.
Maximum return on investment for your study time and maximum safety for your future patients. But before we can even begin to diagnose a broken system, we really have to understand what a perfectly tuned system looks like. We have to start with the baseline.
Yes, you have to know normal to spot abnormal.
Right, because a pregnant body is not just a non-pregnant body carrying a baby in a backpack. It is a completely different physiological ecosystem. I mean, the cardiovascular system completely rewires itself.
That is the perfect place to start. Let's look at the high-yield core of normal maternal physiology. Like I said, to understand the disease, you must understand the adaptation. In a totally healthy pregnancy, the maternal blood volume expands massively.
Like how much are we talking?
We are talking about a 45 to 50% increase in total blood volume by the 3rd trimester.
Wow. Half again as much blood.
Exactly. The body accomplishes this by retaining water and sodium through the renin-angiotensin-aldosterone system, the RAAS. So the kidneys hold onto fluid, the cardiac output increases by up to 50%, the stroke volume increases, and the maternal heart rate increases by like 10 to 15 beats per minute.
Okay.
You have this massive rushing river of extra fluid pumping through the system to support the growing fetus and, to prepare for the inevitable blood loss at delivery.
All right, so I'm picturing all that extra fluid, that massive volume expansion. Logically, if I take a garden hose and turn the spigot on full blast, forcing 50% more water through the same hose, the pressure inside that hose is going to skyrocket.
Yeah.
So a student might logically think, well, more fluid volume equals higher blood pressure. They might assume pregnant women naturally have higher blood pressure.
And that is a very common logical assumption, but it is entirely wrong.
Yeah.
That is your first major clinical twist.
Really?
Yeah. In a normal, healthy pregnancy, systemic vascular resistance actually decreases.
It decreases.
It does. The body vasodilates. Hormones like estrogen, progesterone, and relaxin surge, particularly in the first trimester. These hormones act on the smooth muscle of the blood vessels, causing them to relax, dilate, and just open up wide.
So the hose gets bigger.
Exactly. So despite all that extra blood volume pumping through the system, a healthy pregnant client's baseline blood pressure actually drops. It reaches its lowest point around the end of the first trimester or early second trimester, and then very gradually returns to their pre-pregnancy baseline as they approach term.
Okay, so the healthy baseline is wide open vessels, lower pressure, and massive amounts of blood flow. That actually brings me to an analogy I was sketching out while reading through the source material.
Let's hear it.
Okay, so imagine the blood vessels going to the uterus and the placenta are like a rural, winding two-lane road. It's perfectly fine for everyday local traffic. But now you are building a massive skyscraper at the end of that road to the growing baby.
Right.
You need to deliver an immense amount of supplies like oxygen, glucose, amino acids. A two-lane road cannot handle a fleet of semi-trucks. You need to demolish that road and build a multi-lane, high-speed, low-resistance highway.
That is exactly what the body does, and the body sends in a specialized demolition and construction crew to do it. In obstetrics, we call these cells the trophoblasts.
Trophoblasts.
Right. Starting very early in pregnancy, around week 6 to 8, these trophoblast cells invade the maternal uterine lining. Their entire job is to find the maternal spiral arteries. Those are the vessels that supply the uterus and completely remodel them.
How do they do that? Do they just, stretch them out?
No, it's much more aggressive than that. The trophoblasts actually break down the smooth muscle and the endothelial lining inside those maternal spiral arteries. They strip the arteries of their ability to contract.
Wow, they destroy the muscle.
They do. By destroying that smooth muscle, they turn these narrow, high-resistance vessels into wide, floppy, low-resistance conduits. They literally build your multi-lane highway. Because they lack smooth muscle now, these newly remodeled arteries cannot clamp down. They stay permanently open, allowing a massive, uninterrupted flow of maternal blood to wash over the placenta.
Okay, I see the genius of that system.
Yeah.
The baby needs a constant supply, so the mother's body just removes the very mechanism, the smooth muscle, that could accidentally restrict that supply. But what happens when that construction project goes wrong? When the trophoblasts fail? Because that seems to be the literal origin point of the hypertensive disorders we are talking about today.
It is the absolute genesis of the pathology. This is the high-yield core of the disease process right here. In a hypertensive disorder of pregnancy, the construction crew fails.
Why do they fail?
Well, for reasons we are still trying to fully decode. It could be immunological intolerance, genetic predispositions, or maybe underlying maternal vascular disease like diabetes or chronic hypertension. But whatever the reason, that trophoblast invasion is shallow. It is incomplete. They only remodel a small portion of the spiral arteries.
So the highway basically stays a two-lane road, but the heart is still pumping 50% more blood volume trying to force its way down it.
Exactly. The spiral arteries do not remodel. They retain their thick, smooth muscle lining. This means two devastating things. First, the vessels remain narrow and high resistance. Second, they retain the ability to constrict and clamp down. Yeah, now you have a massive maternal cardiac output trying to force its way through tight, narrow, reactive vessels. The immediate result of this is uteroplacental ischemia. The placenta is not getting enough blood flow. It is literally starving for oxygen.
And the placenta, as an organ, doesn't just passively starve, right? It can just quietly fade away. When the placenta is ischemic, it fights back.
It fights back aggressively, and that is what hurts the mother. When the placenta is ischemic and hypoxic, it panics. It releases a massive cascade of inflammatory markers, reactive oxygen species, and anti-angiogenic proteins, specifically substances like SFLT1 and soluble endoglin, right into the mother's systemic bloodstream.
Let's follow those inflammatory markers into the mother's bloodstream. What exactly are they attacking?
They attack the endothelium.
Which is what exactly?
The endothelium is the delicate microscopic inner lining of every single blood vessel in the mother's body. Think of it as a non-stick Teflon coating that keeps blood flowing smoothly and prevents the vessels from leaking.
Okay, the Teflon coating.
Right. Those placental inflammatory markers act like acid on that Teflon coating. They cause systemic, widespread endothelial dysfunction and damage.
If the Teflon coating is destroyed, what does the vessel do?
The vessel reacts to the injury by spasming. You get widespread systemic vasospasm. Every blood vessel in the mother's body clamps down.
Why? Everywhere.
Everywhere. Furthermore, the damaged endothelium becomes incredibly leaky. Fluid from the bloodstream starts seeping out through the damaged vessel walls and into the surrounding tissues. And finally, the damaged endothelium exposes underlying collagen, which triggers the mother's platelets to rush in and start forming microclots everywhere.
Okay, so vasospasm, leaky vessels, and microscopic clots. If every vessel in the body is suddenly clamping down, well, that entirely explains the hypertension. The blood pressure skyrockets because the container just shrank dramatically.
Precisely. And that is why it matters. Exams will test your understanding of this. The high blood pressure is not the disease itself.
Right.
The high blood pressure is merely the loudest symptom of a systemic vascular fire caused by a starving placenta. If you understand that, every single symptom we are about to discuss will make perfect, logical sense.
Okay, so we have this physiological reality: the placenta is starving, the mother's vessels are clamping down, and the blood pressure is rising. As a nurse, you are standing in triage, and a pregnant client walks in. You put the cuff on her arm, and the machine reads 145/92.
The diagnostic waters are murky.
Exactly. How do we categorize her? The source material gives us a very clear, highly testable dividing line here.
Yes. If you are making flashcards, put 3 stars next to this. The absolute golden rule for your exams. The dividing line of obstetric hypertension is the 20-week mark, 20 weeks of gestation. This timeline is the foundation of your diagnostic tree.
Walk us through how to use that 20-week timeline at the bedside.
Let's start with chronic hypertension. If you have a pregnant client who presents with a blood pressure of 140/90 or higher, and this elevated pressure is diagnosed before they hit 20 weeks of gestation, that is chronic hypertension.
Because the pregnancy hasn't had time to cause it yet.
Exactly. They conceived with it, or they developed it so early in the pregnancy that we clinically assume it is not caused by the pregnancy itself. It is a pre-existing vascular condition.
And what if that timeline shifts to the right? What if she crosses that 20-week threshold?
If a client has had documented normal blood pressure, say 110/70 for the first half of her pregnancy, but then presents with a blood pressure of 140/90 or higher after 20 weeks of gestation, that is gestational hypertension.
Got it.
The timing tells us that the pregnancy itself, that failed placental construction project we just talked about, is the active driver of the pathology.
But why does this timeline matter so much for the exam and for the patient? Like, if the blood pressure is high, isn't the treatment basically the same?
No, absolutely not. The care pathways diverge completely, which is why test writers obsess over this 20-week line. Misdiagnosing the timeline means misunderstanding the trajectory of the patient's risk.
How so?
Well, if a patient has chronic hypertension, your priority is evaluating pre-existing organ damage. Like, do they already have left ventricular hypertrophy? Do they have pre-existing renal disease? And managing their baseline medications safely. But if they have gestational hypertension, you are dealing with a new, active, escalating inflammatory cascade.
The fire just started.
Exactly. Your priority shifts to high alert monitoring for rapid progression to preeclampsia and fetal growth restriction. The timeline dictates your nursing interventions.
Okay, let's talk about expected versus concerning findings when we are just looking at blood pressure readings in triage.
The expected finding, as we discussed, is that the blood pressure drops in the first trimester and slowly climbs back up to the pre-pregnancy baseline by term. It should never exceed 140/90.
And the concerning finding?
The concerning finding, the actual diagnostic criteria, is 2 separate blood pressure readings of 140/90 or higher, taken at least 4 hours apart.
I want to zoom in on that 4-hour window because I can easily see a nurse getting a high reading and immediately panicking or calling the provider to demand a diagnosis. Why? 4 hours?
Because white coat syndrome is real, stress is real, and the physical exertion of waddling into the triage unit is real. You do not diagnose a life-altering hypertensive disorder off one stressful moment.
Makes sense.
You need to establish a sustained pathological pattern of vasospasm. You let the patient rest, preferably on their left side to maximize perfusion, and you recheck in 4 hours. If it remains elevated, you have your diagnosis.
Are there any exceptions to waiting 4 hours?
Yes. The obvious exception here is if the blood pressure is in the severe range 160 over 110 or higher. You do not wait 4 hours to treat a severe stroke-level blood pressure. You treat within minutes, but the formal diagnosis still relies on a pattern over time.
That makes perfect sense. Now, I want to deduce a clinical scenario that I guarantee shows up as a top exam trap.
Lay it on me.
Let's say I have a patient who comes in at week 8. Her blood pressure is beautiful, like 115 over 75. Week 12, it's 118 over 78. But she comes in for her 18-week checkup, and it has spiked to 142 over 92. Since it is new onset during the pregnancy, and her early baseline was normal, wouldn't I categorize that as gestational hypertension? Because she didn't have it when she conceived.
I'm going to firmly shut that logic down right now, because that is exactly how the test writers trick you. The 20-week rule is absolute and unyielding. Even if her blood pressure was perfectly normal at week 8 and 12, if it spikes into the hypertensive range at week 18, it is clinically classified as chronic hypertension.
But why? If she had normal readings earlier, that feels counterintuitive.
Think back to the physiological adaptation we discussed. The normal pregnant body aggressively vasodilates in the first trimester, causing a massive drop in blood pressure. We clinically assume that this physiological drop temporarily masked her underlying chronic hypertension.
So it was there all along.
Exactly. As her blood volume continued to expand into the second trimester, it overcame that vasodilation, and her true chronic hypertension revealed itself. Any hypertensive reading before 20 weeks is chronic. Do not fall for that trap.
Got it. The 20-week wall is impenetrable. Here is another major area of confusion I see in the source notes. A lot of people, even some seasoned nurses, speak about gestational hypertension as if it's just the waiting room for preeclampsia, like they assume it always progresses, that it's just stage 1 of the same disease.
It is a very dangerous misconception. While it is true that up to 50% of clients diagnosed with gestational hypertension will eventually develop end organ damage and progress to preeclampsia, they are classified as distinct diseases based on the clinical presentation at the exact moment of assessment.
So they aren't the same thing.
No. Gestational hypertension is isolated elevated blood pressure after 20 weeks. The vessels are tight, but the organs are still functioning. There is no protein in the urine, no liver damage, no kidney damage, no central nervous system irritability, just the blood pressure.
So your nursing care is based entirely on what is in front of you today, not what might happen tomorrow.
Exactly. You treat the patient based on their current clinical picture while remaining hypervigilant. You are watching them like a hawk, knowing that the silent escalator to preeclampsia could start moving at any moment.
To lock this foundation in, here is a memory anchor for you to take to your exam. When you are staring at a timeline question, just remember, chronic equals conceived with it or it showed up before week 20. Gestational equals grew it, strictly after week 20.
Conceived with it versus grew it. It is simple, it is fast, and it will prevent you from second-guessing yourself on a multiple-choice question.
But what happens when that brick wall of vascular resistance isn't just elevating the numbers on the monitor? When that inflammatory fire, we talked about the leaky vessels, the microclots, the severe vasospasm, when that spreads deep into the mother's vital organs, we cross a terrifying threshold. We move from simple gestational hypertension into the systemic crisis of preeclampsia.
And that transition is what I call the silent escalator. It is the most treacherous part of obstetric nursing. A patient can be sitting in her hospital bed, scrolling on her phone, feeling completely normal, while her microscopic vasculature is actively shredding her platelets and starving her liver of oxygen. The disease escalates subclinically before the grand finale of symptoms appear.
Let's isolate the high-yield core here. If I'm looking at a patient chart, how do we define preeclampsia clinically? What pushes a patient from gestational hypertension into this new category?
Preeclampsia is defined as new-onset hypertension after 20 weeks of gestation plus evidence of end organ damage.
Plus the organs.
Right. The inflammatory cascade has officially breached the organs. We divide this diagnosis into 2 strict categories to guide our interventions: preeclampsia without severe features and preeclampsia with severe features.
Let's break those down. What does without severe features actually look like?
Preeclampsia without severe features is your baseline diagnostic entry point. The client has the required blood pressure 140 over 90 or higher on 2 occasions at least 4 hours apart. And traditionally, this is coupled with proteinuria.
Protein in the urine. Why does that happen? Let's connect the pathophysiology.
Remember the leaky endothelium? The Teflon coating?
Yeah.
Well, the kidneys are essentially massive balls of microscopic blood vessels called glomeruli. They are the body's filters. When the endothelial inflammation hits the kidneys, the glomeruli swell up and get damaged, a condition called glomerular endotheliosis. The filter gets leaky. Large protein molecules, like albumin, which are supposed to stay in the blood, slip through the damaged filter and spill into the urine.
So high blood pressure plus a leaky kidney filter equals preeclampsia without severe features.
Yeah.
What escalates it to with severe features?
The addition of the word severe is your cue that the end organ damage is escalating to a life-threatening level. The disease is accelerating. You diagnose preeclampsia with severe features if either the blood pressure hits the severe range or if specific vital organs begin to fail.
Let's define the severe blood pressure range first.
Severe range blood pressure is a systolic of 160 or higher, or a diastolic of 110 or higher. Notice the OR.
Right.
If a patient's blood pressure is 165/85, they meet the criteria for severe features based on the systolic alone. If it is 135/115, they meet it based on the diastolic alone. At this pressure, the cerebral vessels are at extreme risk of rupture.
So 160/110 is the magic threshold. But you mentioned organ failure. If their blood pressure isn't in that severe range, say it's only 145/95, can they still be diagnosed with severe features?
Absolutely, and this is a critical concept. If the blood pressure is mildly elevated, but the patient presents with signs of severe central nervous system involvement, renal failure, liver failure, or hematological breakdown, they are immediately categorized as having preeclampsia with severe features. The organ damage supersedes the blood pressure numbers.
Let's go organ by organ because this is exactly what the nurse has to assess at the bedside. Let's look at expected versus concerning findings. A pregnant woman at 32 weeks comes into triage complaining that her shoes don't fit anymore because her ankles are swollen.
Mild dependent lower extremity edema. So, ankle swelling is an expected finding in a normal, healthy third trimester pregnancy.
Oh, really? It's just normal.
Yeah. The heavy uterus compresses the pelvic veins, slowing venous return, and the increased fluid volume naturally pools in the lowest points of the body due to gravity. We note it, but we do not panic over mild ankle edema.
So if ankle swelling is normal, what fluid shifts are concerning? What makes you prioritize this patient immediately?
You are looking for pathological fluid shifts caused by the leaky endothelium. You are looking for sudden, rapid weight gain. We're talking 3, 4, or 5 pounds in a matter of days.
That's a lot.
Yes, that is not fat. That is massive, sudden fluid retention. You are also looking for facial or periorbital edema. If the tissue around her eyes is swollen shut, or her hands are so swollen she can't bend her fingers or take off her rings, that means fluid is leaking out of her damaged capillaries systemically, not just pulling from gravity.
What about the brain? The source material highlights neurological symptoms heavily.
Neurological symptoms are a massive priority. You must ask about them because a patient might just attribute them to normal pregnancy fatigue. You are looking for a new onset, unrelenting frontal headache that is not relieved by Tylenol.
Why the headache? Is it just stress?
No, it is mechanical. The sheer force of the high blood pressure overcomes the brain's ability to auto-regulate its blood flow. The cerebral vessel spasm, the endothelium leaks, and you get cerebral edema, actual swelling of the brain tissue inside the rigid skull. Exactly. That swelling and ischemia cause the excruciating headache. It also causes visual changes. The vasospasm hits the tiny vessels in the retina and the occipital lobe. Clients will report blurred vision, seeing floating spots called scotomata, or flashes of light. If a patient reports seeing flashing lights, their brain is in profound distress.
This brings up a physical assessment skill that feels incredibly specific to OB deep tendon reflexes, or DTRs. A nurse is tapping the patient's knee with a reflex hammer. Explain the mechanism here. What is the reflex actually telling us about the brain?
Think of a reflex arc. When you tap the patellar tendon just below the kneecap, you stretch the muscle. A sensory signal travels to the spinal cord, and a motor signal comes right back, telling the leg to kick. Normally, the brain sends a continuous, gentle, inhibitory signal down the spinal cord to dampen that reflex, keeping the kick moderate. A normal reflex is graded as a 2+ cold.
But in severe preeclampsia,
that cerebral edema we just talked about, the swelling in the brain, irritates the cortex and cuts off that inhibitory signal. The central nervous system becomes wildly hyperirritable. When you tap the knee, there is no dampening signal from the brain. The reflex becomes brisk, hyperactive. You will grade it a 3+ or a 4+ swin. You might even elicit clonus.
clonus. Describe what that looks and feels like at the bedside.
To check for clonus, you support the patient's leg and sharply dorsiflex their foot, pushing their toes up toward their knee and hold it there. If the nervous system is dangerously irritable, the foot won't just stay there. It will forcefully, rhythmically beat or tap against your hand. 2 beats, 3 beats, 4 beats of clonus. If you feel clonus, the nervous system is like a rubber band stretched to its absolute limit. It tells you that a seizure could be imminent at any moment.
Wow. Moving down from the brain, let's look at the abdomen. The text mentions right upper quadrant or epigastric pain as a severe feature.
Oh, yeah.
So specific. Why the right upper quadrant?
Because that is exactly where the liver sits. Remember the microclots and the vasospasm? They don't just happen in the kidneys and the brain. They happen in the hepatic sinusoids, the blood vessels of the liver. The liver tissue becomes ischemic, it becomes inflamed, and it begins to swell.
But the liver is surrounded by a capsule, right?
Yes, a fibrous sheath called Glissen's capsule. As the liver tissue swells from the inflammation and microscopic bleeding, it stretches Glissen's capsule tightly. That severe stretching of the capsule causes intense, unremitting pain in the right upper quadrant, radiating to the back or right in the center of the epigastric area.
Do patients know it's their liver?
No, and that's the danger. It is often misdiagnosed by patients as severe heartburn or indigestion. If a pregnant patient complains of new severe heartburn that antacids don't fix, you must suspect liver ischemia.
So, translating all of this pathophysiology into priority nursing actions. What exactly does the safe, competent OB nurse do with this knowledge?
First, proactive, aggressive assessment. You must ask about headaches, visual changes, and upper abdominal pain at every single interaction with a pregnant client past 20 weeks. Triage, routine clinic visits, labor and delivery every time. Do not wait for them to volunteer the information because they might think it's just normal pregnancy discomfort. Second, you must take a meticulously accurate blood pressure.
The source material is surprisingly strict about the mechanics of taking a blood pressure. It feels like basic nursing 101, but they emphasize it heavily. Why?
Because in obstetrics, a bad reading can literally kill a patient if it leads to a misdiagnosis, or trigger a massive cascade of unnecessary high-alert medications if it's falsely elevated. You need the correct cuff size. The bladder of the cuff must encircle at least 80% of the patient's arm.
And their position.
The client must be seated upright, feet flat on the floor, and the arm must be actively supported at the level of the heart. Furthermore, they must have abstained from caffeine and tobacco for at least 30 minutes prior.
What happens if I grab a regular adult cuff for a patient with a larger arm because I'm in a hurry?
If you use a cuff that is too small, the reading will be artificially high. You might diagnose severe preeclampsia on a patient whose actual pressure is normal. If you let their arm hang down by their side, gravity will increase the hydrostatic pressure, falsely elevating the reading. You cannot cut corners on this assessment.
Priority nursing action number 3 involves evaluating the labs. The underlying vascular destruction leaves a very clear chemical footprint in the blood. The sources gave us some critical values to memorize. Let's list the high-yield numbers that mean the patient has severe features.
You need to know these colds. First, platelets. Less than 100,000. Normal is 150,000 to 400,000. If it drops below 100,000, that indicates severe thrombocytopenia.
Why are the platelets disappearing?
They aren't disappearing, they are being consumed. As the endothelium is damaged systemically, platelets rush in to patch the microscopic holes. They aggregate and form microthrombi all over the body. They're being used up faster than the bone marrow can produce them.
Got it. What else?
Next, liver enzymes, AST and ALT. If these are elevated to double the normal upper limit, that signifies severe liver ischemia and cellular death. Then, renal function serum creatinine, greater than or equal to 1.1 milligrams per deciliter, or a doubling of their baseline creatinine. The kidneys are shutting down, unable to filter waste. And finally, the 24-hour urine protein showing 300 milligrams or more.
Okay, I have to stop you there and bring up a massive point of confusion, a huge trap for students studying this material. Wait, I thought you had to have protein in the urine to be diagnosed with preeclampsia. Isn't that the classic triad? High blood pressure, swelling, and protein. If the kidneys aren't leaking protein, how can it be preeclampsia?
I am so glad you're pulling this thread, because this is an outdated legacy NCLEX trap that still catches students and even veteran nurses every single day. Listen to this very carefully. Proteinuria is no longer strictly required to diagnose preeclampsia.
It's not, but it's in all the old textbooks.
It is, but the clinical guidelines changed drastically. Years ago, protein was mandatory for the diagnosis. But ACOG, the American College of Obstetricians and Gynecologists, realized a fatal flaw in that requirement.
What was the flaw?
The end organ damage does not happen in a predictable linear order. Some women were developing profound liver failure, their platelets were dropping to 50,000, or they were developing fluid in their lungs, pulmonary edema. But because their urine dipstick didn't show protein yet, doctors were withholding the preeclampsia diagnosis and withholding life-saving treatment. Women were seizing and dying while waiting for protein to show up in a cup.
Wow. That is a massive paradigm shift. So what is the rule now?
Today, if a client has new-onset hypertension after 20 weeks, and they have absolutely NO protein in their urine, but their platelets are 80,000, or their liver enzymes are doubled, or they complain of a severe headache and visual changes, they have preeclampsia with severe features. Period.
So the protein doesn't matter if the other organs are failing?
Exactly. The presence of any severe end organ damage in the brain, liver, kidneys, or blood confirms the diagnosis, even if the renal filter hasn't started leaking protein yet. Do not let a test question trick you by saying, urine protein is negative, therefore it cannot be preeclampsia.
That is the perfect way to look at it. Protein is a powerful clue, but it is not the absolute rule. Any failing organ counts. So let's follow the clinical timeline. We have a patient, the inflammatory fire is raging, the blood pressure is severe, the organs are taking damage. The only true cure for this disease, as the source notes point out, is birth. The delivery of the placenta physically removes the source of those anti-angiogenic factors.
Exactly. Once the placenta is gone, the signal to attack the endothelium stops.
But what if the baby is only 28 months gestation? Delivering a 28-weeker comes with massive life-threatening complications for the neonate: brain bleeds, respiratory failure, bowel necrosis. We need a bridge. We need a way to artificially suppress the mother's vascular fire to keep her alive and buy the baby time to grow in utero.
And that vital bridge is built entirely out of pharmacology. Medications make up a massive percentage of nursing exams because administering them safely, understanding their mechanisms, and recognizing their toxicities is the absolute core of nursing practice. Understanding why a drug is given rather than just memorizing a flashcard will save lives.
Let's start with the preventative side, the early intervention, aspirin.
Yes, specifically low-dose aspirin, usually 81 milligrams. For clients identified as high risk for preeclampsia in their first trimester, maybe they have chronic hypertension, a history of preeclampsia in a previous pregnancy, type 1 or type 2 diabetes, or an autoimmune issue like lupus ACOG, recommend starting low-dose aspirin daily between 12 and 28 weeks of gestation.
I want to understand the mechanism here. Why aspirin? I take aspirin for a headache.
Yeah.
How does it stop a placental highway from failing?
It comes down to a microscopic balancing act in the blood vessels between two chemicals, thromboxane A2 and prostacyclin. Thromboxane A2 causes vessels to constrict and platelets to clump together. Prostacyclin causes vessels to dilate and prevents clumping. In preeclampsia, the damaged endothelium pumps out massive amounts of thromboxane A2.
Constriction and clotting. The exact things we don't want.
Exactly. Low-dose aspirin selectively inhibits the production of thromboxane A2. By blocking the constrictor, it tips the balance back toward prostacyclin. It promotes vasodilation and prevents those platelets from aggregating in the delicate microvasculature of the placenta. It chemically props the highway open, allowing better perfusion and delaying or preventing the onset of the severe inflammatory cascade.
Brilliant. Moving on to the actual antihypertensives, the drugs we use when the blood pressure hits that severe 160/110 mark. The source material highlights 4 main pharmacological weapons: labetalol, nifedipine, hydralazine, and methyldopa. Let's hit the high-yield facts for each, focusing on the mechanism and what the safe nurse needs to watch out for.
Let's start with labetalol. This is frequently a first-line acute medication. It is a beta blocker, but more specifically, it blocks both alpha-1 and beta receptors. By blocking alpha-1 receptors on the blood vessels, it causes vasodilation. By blocking beta-1 receptors on the heart, it slows the heart rate, it drops blood pressure very effectively.
But as a nurse pushing an IV beta blocker, what is the trap?
You must watch for severe maternal bradycardia. And here is the classic exam contraindication. Labetalol is strictly contraindicated in clients with a history of asthma or heart block.
Asthma. Why asthma?
Because beta-2 receptors are located in the smooth muscle of the lungs. They keep the airways open. Labetalol is non-selective. It blocks those lung receptors too. In an asthmatic patient, blocking beta-2 receptors can trigger a fatal bronchospasm. You fix the blood pressure, but the patient stops breathing.
Crucial point. Check the respiratory history before pushing labetalol. Next, nifedipine.
Nifedipine is a calcium channel blocker, usually given orally. Smooth muscle cells need calcium to contract. Nifedipine blocks calcium from entering the cells of the blood vessels, forcing the vessels to relax and massively vasodilate. It's fantastic for blood pressure control.
What's the downside of massive sudden vasodilation?
Gravity takes over. Because the vessels dilate so effectively, a major side effect is profound orthostatic hypotension. The patient stands up to go to the bathroom, the blood pools in their newly dilated leg vessels, it doesn't return to the brain, and they pass out on the floor. Patient teaching priority instruct them to change positions incredibly slowly.
Like slow movements.
And the classic pharmacology exam trap for nifedipine, no grapefruit juice. Grapefruit juice inhibits an enzyme in the gut and liver called CYP3A4, which is responsible for breaking down nifedipine. If they drink grapefruit juice, the drug builds up to toxic levels, causing dangerous hypotension.
Moving to the third weapon, hydralazine.
Hydralazine is a direct-acting, smooth muscle vasodilator. We use it IV during an acute, severe hypertensive crisis. It works incredibly fast, but sometimes it works too fast. The biggest risk is a precipitous, uncontrolled drop in maternal blood pressure.
Let's deduce why maternal hypotension is dangerous in this specific context. If the goal is to lower the BP, why are we worried if it drops to, say, 100/60?
It comes back to our overarching theme, perfusion. The spiral arteries supplying the placenta are already damaged and narrow. They need a higher driving pressure from the mother's heart just to push blood through. If you push IV hydralazine and suddenly drop the mother's systemic pressure too low, the driving force vanishes. The blood flow to the placenta plummets instantly. The fetus becomes profoundly hypoxic.
How does the nurse know that is happening? The baby can't tell you.
The fetal heart rate monitor will scream at you. You will immediately see late decelerations, the fetal heart rate dropping after a contraction, indicating uteroplacental insufficiency or prolonged fetal bradycardia. When you push IV hydralazine, your eyes must be bouncing continuously between the maternal blood pressure cuff and the fetal monitor. You are walking a tightrope between maternal stroke risk and fetal asphyxia.
And finally, methyldopa.
Methyldopa is an older, centrally acting antiadrenergic. It works in the brainstem to reduce sympathetic outflow. It's rarely used for acute, severe spikes, but it is excellent and very safe for chronic baseline maintenance. The main nosing implication is that it can cause significant maternal drowsiness, dry mouth, and flu-like lethargy.
Okay, let's switch gears to a medication that has absolutely nothing to do with blood pressure, but is inextricably linked to preeclampsia management: betamethasone. A student might logically look at the orders and ask, my patient has severe preeclampsia, her vessels are clamped down. Why in the world are we giving her a powerful corticosteroid?
It is a critical thinking question. The answer is that betamethasone is not for the mother at all. It is entirely for the fetus.
For the fetus?
Yes. If a client is admitted with severe preeclampsia, we know the definitive cure delivery could be forced upon us at any moment to save her life. If the fetus is premature, say 28 or 30 weeks, their lungs are structurally immature. They lack a vital substance called surfactant.
Surfactant is like the physiological soap that keeps the tiny air sacs, the alveoli, in the lungs from sticking closed when the baby exhales, right?
Exactly. Without surfactant, every breath is like trying to blow up a wet balloon. The baby will suffer respiratory distress syndrome. So we give the mother deep intramuscular injections of betamethasone. The steroid crosses the placenta, enters the fetal circulation, and stimulates the fetal type 2 pneumocytes in the lungs to rapidly accelerate the production of surfactant.
How fast does it work?
We want to try to delay delivery for at least 48 hours after the first injection to give the steroid time to reach maximal efficacy, provided the maternal and fetal conditions remain stable enough to wait. It is a calculated gamble to mature the fetal lungs before the maternal environment becomes totally unsurvivable.
Right. Take a deep breath. We have arrived. It is time to talk about the heavyweight champion of OB pharmacology, the medication that haunts the dreams and the simulation labs of nursing students everywhere: magnesium sulfate.
Magnesium sulfate is arguably the single most important drug to master for obstetric nursing exams, and for safe OB clinical practice, it is a high-alert, dangerous, life-saving medication.
Let's clear up the biggest, most pervasive exam trap right out of the gate. A patient with severe preeclampsia has a blood pressure of 170/115. The provider orders a magnesium sulfate fourth bolus and continuous drip. Why are we giving it?
I will say this slowly, and I want you to burn this in your memory because test writers will try to trick you on this from every conceivable angle. Magnesium sulfate is a central nervous system depressant. It is given for seizure prophylaxis.
not blood pressure.
Exactly. It is given to raise the seizure threshold in the brain, preventing the mother from seizing, or to stop an active seizure if she is already having one. It is not given as a primary antihypertensive to lower blood pressure.
But wait, I've seen patients on mag drips, and their blood pressure often does come down a bit. Isn't that the point?
No, that is a secondary effect. Magnesium relaxes smooth muscles systemically, so yes, you might see a mild transient drop in blood pressure, but that is a side effect, not the therapeutic goal. If a test question asks, what is the primary indication for initiating a magnesium sulfate infusion in a preeclamptic client, the answer is always to prevent eclampsia, or seizure prophylaxis. Never choose to lower blood pressure. If you want to lower blood pressure, you use labetalol or hydralazine.
So how does magnesium actually stop a seizure in the brain?
It acts at the neuromuscular junction. Magnesium chemically competes with calcium. Normally, calcium enters the nerve terminals and triggers the release of acetylcholine, which tells the muscles to contract or the nerves to fire. Magnesium blocks that calcium channel. It blocks the release of acetylcholine. It literally quiets down the electrical storm in the central nervous system.
But if it depresses the central nervous system, that sounds dangerous. Let's talk about expected versus concerning findings when a patient is on a mag drip. It's a high alert med for a reason.
When you start the initial bolus of magnesium, a massive dose hits the patient's system. The patient is going to feel awful. Expected findings include intense flushing, feeling like they're burning up from the inside, severe diaphoresis or sweating, and mild lethargy or sedation. They will tell you they feel like they have the worst flu of their life.
So you just warn them.
Yes. As a nurse, you must provide anticipatory guidance. You hold their hand, give them a cold washcloth, and educate them that this intense heat is an expected side effect of the smooth muscle relaxation.
But where is the line? Where do we cross from expected misery into life-threatening magnesium toxicity?
The line is distinct and measurable. Magnesium depresses the central nervous system. If the levels get too high, it doesn't just quiet the hyperactive nerves, it depresses the critical life-sustaining functions. Concerning findings, toxicity include the respiratory rate dropping below 12 breaths per minute, the diaphragm is a muscle, and the magnesium is blocking the signal telling it to move.
What about those reflexes we talked about earlier?
If the magnesium level is therapeutic, the 4+ hyperactive reflexes should calm down to a normal 2+ part. But in toxicity, the deep tendon reflexes become completely absent. You tap the knee and there is zero response, a grade of 0. The neuromuscular junction is completely blocked. You will also see severe hypotension and an altered level of consciousness. The patient becomes unarousable, slurring words, or unable to stay awake.
And there's one more critical assessment piece, urine output. Why is urine output so intimately, dangerously connected to magnesium toxicity?
This is the high-yield physiological connection you must make to understand this drug. Magnesium sulfate is cleared from the body almost entirely by the kidneys. It is excreted in the urine. But remember the pathology of preeclampsia. The leaky glomeruli, the swollen kidneys.
Yeah.
Preeclampsia inherently damages renal function. If the preeclampsia worsens and causes acute renal failure, the kidneys stop making urine.
And if they stop making urine, the exit door for the magnesium is locked.
Exactly. If the kidneys shut down, the continuous IV drip of magnesium has nowhere to go. It rapidly accumulates in the bloodstream.
Right.
Within hours, the serum level spikes into the toxic range, the reflexes vanish, and the patient stops breathing.
So, mapping out the priority nursing actions for a patient on a mag sulfate drip. This isn't a check on them once a shift situation.
It is intense, one-on-one critical care nursing. You are at the bedside constantly. You're performing hourly vital signs, focusing intensely on the respiratory rate and oxygen saturation. You are performing continuous, hourly, deep tendon reflex checks to ensure they haven't disappeared. And you must maintain strict intake and output monitoring. This means every single patient receiving magnesium sulfate must have an indwelling Foley catheter placed, and it must have a urometer attached.
A urometer, for students who haven't seen one, that's the rigid, clear plastic box attached to the front of the Foley drainage bag that allows you to measure tiny amounts of urine. Exactly right.
Yes, you cannot eyeball the bag and guess their urine output. You need to open the stopcock hourly and measure precisely how many milliliters they produced. If the urine output drops below 30 milliliters an hour, it is a priority alert. The kidneys are failing, the magnesium is building up, and you are on a collision course with respiratory arrest.
Let's run the worst-case scenario. You walk into the room for your hourly check. The patient is unarousable. Her respiratory rate is 8 breaths per minute. You tap her knee, and there are no reflexes. What is the absolute first intervention?
Your very first immediate action is to reach over and turn off the IV magnesium sulfate infusion. Stop the drug. Do not call the doctor first. Stop the pump. Then provide immediate respiratory support, bag valve mask, ventilation if necessary, call for the rapid response team, and administer the antidote.
The antidote? Another non-negotiable fact for the exam.
The antidote is calcium gluconate. Because magnesium competes with calcium at the cellular level, flooding the system with calcium pushes the magnesium off the receptors. You must ensure that calcium gluconate is immediately available at the bedside of any patient receiving magnesium sulfate. Not in the pharmacy, not locked in the P6 down the hall. In the room, at the bedside, ready to be drawn up and given IV push over 3 minutes to reverse the cardiac and respiratory depression.
Here is a memory anchor for magnesium. Remember the word drag. D-R-A-G. Magnesium makes you drag. It depresses the central nervous system. It reduces respirations. It causes absent reflexes. And it requires strict monitoring of the genitourinary system, the kidneys. Too much drag, and the breathing and the reflexes stop entirely.
I love that. DRAG. It covers all the priority assessments. And before we leave pharmacology, let's highlight one more major exam trap regarding antihypertensives, the RAAS inhibitors. Angiotensin-converting enzyme inhibitors, the ACE inhibitors like lisinopril, or the ARBs like losartan.
Right. A nursing student might look at a patient with a blood pressure of 160/100 and think, well, lisinopril is one of the most common effective blood pressure medications in the world. Why don't we just give her that?
Never. ACE inhibitors and ARBs are strictly, unequivocally contraindicated during all trimesters of pregnancy. They carry a black box warning. They are highly teratogenic.
How do they harm the baby?
The fetal kidneys rely on the renin-angiotensin system to develop and function. If you give the mother an ACE inhibitor, it crosses the placenta and shuts down the fetal kidneys. The fetus stops producing urine. Fetal urine is the primary component of amniotic fluid in the 2nd and 3rd trimesters.
So no fluid.
Right. Without it, you get severe oligohydramnios, no amniotic fluid. The fetus is crushed by the uterine walls, causing limb deformities, craniofacial abnormalities, massive intrauterine growth restriction, and neonatal renal failure resulting in death. If you see lisinopril or losartan as an option for a pregnant patient on an OB exam, it is a distractor. It is the wrong answer.
Okay, we've laid the physiological foundation, we've ridden the silent escalator of preeclampsia, and we've built the pharmacological bridge to try and hold the disease at bay. But we have to face reality. Despite the early aspirin, despite the labetalol, despite the continuous drip of magnesium sulfate, sometimes the inflammatory fire simply burns too hot. The disease breaks through our defenses. What happens when the central nervous system completely short-circuits, or when the hematological system implodes?
We enter the realm of true obstetric emergencies, eclampsia and HELLP syndrome. These are the situations where seconds count, where maternal codes happen, and where your absolute mastery of nursing prioritization is the only thing standing between life and death.
Let's tackle eclampsia first. We know the prefix pre means before, so preeclampsia is the prelude. What defines the main event?
By definition, eclampsia is the onset of generalized tonic-clonic seizure activity or a coma in a pregnant client, usually one with a history of preeclampsia without any other underlying neurological cause like pre-existing epilepsy or a brain tumor. It is the ultimate manifestation of severe central nervous system involvement.
When is the patient at risk for this? Is it just the stress of pushing during labor?
That is a critical point of failure for many clinicians. Eclampsia does not just happen in the delivery room. It can happen antepartum weeks before birth while she is watching TV at home. It can happen intrapartum during the intense physiological stress of labor. And crucially, it can happen postpartum. The danger does not vanish the second the placenta is delivered. The massive vascular damage, the cerebral edema, and the endothelial inflammation take days to heal. A patient can seize 48 hours or even up to a week after delivery. Postpartum preeclampsia and eclampsia are very real and very deadly.
Let's visualize the mechanism. What exactly is happening inside the skull to trigger a sudden violent seizure?
It is the catastrophic failure of cerebral autoregulation. Remember that the brain normally keeps his blood flow constant despite changes in systemic blood pressure. But when the blood pressure hits 160, 180, or 200 systolic, the sheer hydrostatic force blows past the brain's defenses. The cerebral vessels spasm violently, causing focal ischemia. Areas of the brain are choking for oxygen. Simultaneously, the damaged endothelium leaks fluid into the brain tissue, causing massive cerebral edema. This combination of swelling and hypoxia creates a hyperexcitable focus in the cortex, which fires rapidly and triggers the massive electrical storm of a tonic-clonic seizure.
And while the brain is short-circuiting, the blood and the liver can undergo their own catastrophic failure. That brings us to HELLP syndrome. Let's break down that acronym because, as the sources note, it is literally a laboratory diagnosis. You can't diagnose it just by looking at the patient.
Exactly. HELLP is a multi-system organ failure variant of severe preeclampsia. The acronym stands for H. hemolysis, the destruction of red blood cells. EL, elevated liver enzymes, indicating severe hepatic ischemia and necrosis. LP, low platelets, indicating massive consumption in the microvasculature.
I want to dig into the hemolysis part. How are the red blood cells being destroyed? Is it an immune attack?
No, it is purely mechanical trauma, microangiopathic hemolytic anemia. Imagine that damaged, leaky endothelium again. As it gets damaged, fibrin strands are laid down across the inside of the tiny blood vessels to try and patch the leaks, almost like microscopic barbed wire. When the mother's red blood cells are forced through these narrowed, fibrin-laced vessels under high pressure, they are literally sliced apart. They are sheared. If you look at a blood smear under a microscope, you won't see nice round red blood cells. You will see jagged, broken fragments called schistocytes.
So the red blood cells are being shredded, causing anemia. The platelets are being used up to patch the holes, causing the low platelets. And the liver. What is happening to the liver in HELLP syndrome?
The microclots completely clog the hepatic sinusoids. The liver tissue dies periportal necrosis. The liver swells massively against its capsule. If HELLP syndrome is not recognized and treated with immediate delivery, the liver capsule can literally rupture. A hepatic hematoma bursts, causing catastrophic, often fatal, internal hemorrhage.
That is terrifying. Which brings me to a critical exam trap regarding HELLP syndrome. I'm going to play the confused nursing student again. Okay, so HELLP syndrome is the absolute worst, most severe end-stage form of preeclampsia, which means, logically, to have HELLP syndrome, the patient's blood pressure must be sky high. Like 180 over 120, right?
I am throwing a massive red flag on that assumption. That is one of the most dangerous clinical traps in obstetrics. Up to 15% of patients who develop HELLP syndrome do not present with classic severe hypertension. They might not even have a trace of protein in their urine.
Wait, really? Their blood pressure might be completely normal. How is that a hypertensive disorder?
It might be only mildly elevated, like 135 over 85, or occasionally perfectly normal. HELLP syndrome is a bizarre, destructive variant of the disease process where the microvascular damage and the inflammatory cascade target the liver and the hematological system intensely without necessarily manifesting as extreme systemic arterial vasospasm.
So how do they present if the blood pressure isn't screaming at you to intervene? What is the clue?
They present complaining of feeling terrible, malaise, nausea, vomiting, flu-like symptoms, and crucially, they present with severe right upper quadrant or epigastric pain. If a pregnant woman comes into triage at 34 weeks complaining of what seems like a nasty stomach bug or severe heartburn, but it's localized to that right upper quadrant, you absolutely cannot dismiss it just because her blood pressure is 120 over 80. In a pregnant patient, new-onset RUQ pain is liver ischemia, liver hematoma, or HELLP syndrome until proven otherwise by lab work. It is a priority to report it immediately and draw the HELP labs, the CBC, AST, ALT, and bilirubin. Do not let a normal blood pressure lull you into a false sense of security.
Okay, let's move from diagnosis to action. You are in the room. You are talking to a patient with severe preeclampsia. Suddenly, her eyes roll back, her jaw clenches, her body goes rigid, and she begins a violent tonic-clonic eclamptic seizure. What is the very first immediate thing the SAFE-OB nurse does?
You stay with the patient and you call for help. Hit the emergency call bell, yell into the hallway, activate the code system. Do not leave the room to run and find a doctor. You are the primary responder.
The team is on the way. What are your physical interventions?
Airway, breathing, circulation. Your absolute overriding priority is protecting the maternal airway and ensuring physical safety. You must immediately forcefully assist the patient into a side-lying position, preferably the left lateral position.
Let's explain the mechanics of that. Why the side and why the left side specifically?
Two critical anatomical reasons. First, during a seizure, the patient cannot manage her own oral secretions, and she may vomit. Turning her on her side allows gravity to drain saliva and emesis out of the mouth, preventing her from aspirating fluid into her lungs, which would cause aspiration pneumonia or immediate airway obstruction. Second, the left lateral position shifts the massive, heavy, pregnant uterus off the inferior vena cava.
The vena cava being the massive vein returning all the blood from the lower body back to the right side of the heart.
Exactly. If she is flat on her back, the uterus compresses that vein. Cardiac output drops precipitously. By rolling her to her left side, you physically unkink the hose. You restore venous return to the heart, which means you restore oxygenated blood flow out to the brain to help stop the seizure, and down to the placenta to keep the baby alive.
What about oxygen?
Yes. During the tonic phase of the seizure, her diaphragm is locked. She is not breathing. She is rapidly becoming hypoxic. You apply high-flow oxygen via a non-rebreather mask at 10 to 15 liters per minute to flood her lungs with oxygen so that when she does take a breath, she gets maximum benefit.
And what are the things you absolutely do not do during a seizure? What are the exam traps that will automatically fail you?
Never, ever attempt to insert a padded tongue blade, an oral airway, or your fingers into the mouth of an actively seizing patient. That is an antiquated, dangerous practice. The jaw muscles are incredibly powerful during a seizure. You will break their teeth or they will bite your finger off and you will push the tongue back and occlude the airway further. Secondly, never physically restrain their limbs to stop the shaking. You will cause muscle tears, bone fractures, or joint dislocations. You pad the side rails with pillows, you protect her head from hitting the hard plastic of the bed, but you let the seizure run its course while maintaining that left lateral position.
Okay, the violent shaking stops, the seizure ends, the patient enters the post-ictal phase. She's unresponsive, breathing heavily, completely exhausted. What is the priority now?
Now, your eyes must dart straight to the fetal monitor. During that 1 to 3 minute maternal seizure, the mother was profoundly hypoxic. That means the baby was cut off from oxygen. Furthermore, the intense sympathetic discharge during a seizure often causes the uterus to hyperstimulate. It clamps down in a tetanic contraction, completely squeezing off the already damaged placental blood vessels.
If the baby is cut off from oxygen, what does that look like on the fetal strip?
You are going to see a terrifying monitor. You will likely see severe, prolonged decelerations, the heart rate dropping down into the 70s or 60s and staying there. Or you will see severe fetal bradycardia. The baby is suffocating in utero. You are now running an in utero fetal resuscitation.
What is the medical intervention to stabilize this chaos?
If the mother was not already on magnesium sulfate, you anticipate an immediate stat order for a 4 to 6 gram IV bolus to prevent a second seizure. If she was already on it, the provider will order an additional bolus. If the seizure does not stop, or if she has recurrent seizures without regaining consciousness status epilepticus, you anticipate giving a fast-acting benzodiazepine like 5-lorazepam or diazepam to forcefully break the seizure activity.
And when she is breathing, the mag is in, and she is momentarily stabilized. What about the baby?
You begin rapid, chaotic preparations for immediate birth, almost certainly via an emergency cesarean section. Once eclampsia occurs, the maternal-fetal environment is fundamentally toxic and no longer survivable. You do not wait for the baby to reach term. You deliver to save the mother's life.
And is it the same aggressive timeline for HLLP syndrome? Is there any expectant management like, her platelets are 80,000, let's keep her on bed rest for a few days, give some steroids, and see if the liver enzymes improve?
Absolutely not. HELLP syndrome is a definitive indication for immediate birth regardless of gestational age. The inflammatory cascade has reached a terminal velocity. You cannot reverse HELLP syndrome while the placenta is still inside the body. You stabilize the mother hemodynamically. You anticipate the immediate need for massive blood product transfusions, pooling platelets, packed red blood cells, and fresh frozen plasma to replace what the microclots destroyed, and you move to the operating room.
We have covered an immense, overwhelming amount of ground. From the initial failure of a microscopic construction crew in the spiral arteries all the way to the organized chaos of an eclamptic seizure code, we've traced the pathology, the symptoms, the pharmacology, and the emergencies.
It is a complex, terrifying disease process. But if you truly understand the why, the failed highway, the starving placenta, the inflammatory markers shredding the endothelial Teflon, the organs swelling and failing, then every single nursing action, from checking a reflex to turning off mag drip, makes perfect logical sense. You aren't just memorizing, you are understanding.
Let's distill all of this down. We are going to wrap this up with our outro. If you are exhausted from studying, if your brain is full, and you only have room to remember 5 core concepts from this massive deep dive, these are the 5 things you write down on your scratch paper the second you sit down for your exam. Number 1, the timeline is everything. The 20-week mark is your absolute diagnostic wall. If the hypertension is diagnosed before 20 weeks, it is chronic. If it spikes after 20 weeks, it is gestational. That timeline dictates the entire care pathway and determines if the pregnancy itself is the cause.
Number 2, proteinuria is a clue, not an absolute rule. Severe preeclampsia can, and frequently is, diagnosed based entirely on end organ damage, doubled liver enzymes, drastically low platelets, high creatinine, severe headaches, or visual changes, even if the urine dipstick has 0 protein in it. Do not fall for the old trap that requires protein for the diagnosis.
Number 3, know your magnesium sulfate intimately. It is given to prevent seizures by depressing the central nervous system, not to lower blood pressure. Because it causes CNS depression, you must rigorously, hourly monitor the respiratory rate, deep tendon reflexes, and hourly urine output via a urometer. And the antidote, calcium gluconate, must be physically present at the bedside.
Number 4, right upper quadrant pain is a screaming alarm bell. It is not heartburn, and it is not the baby kicking the ribs. It signifies liver involvement, liver swelling against Glissan's capsule, and potential HLLPO syndrome. HLLP is a life-threatening emergency requiring immediate delivery, and remember the trap it can occur even if the blood pressure is completely normal.
And number 5, safety first in eclampsia. If a seizure occurs, do not leave the patient. Call for help immediately. Forcefully turn them to the left lateral position to prevent aspiration and restore venous blood flow off the vena cava, apply high-flow oxygen, and protect the airway. Never physically restrain their shaking limbs, and never ever insert a tongue blade into their mouth.
Those 5 points are your high-yield core. They will save you points on test day, and they will save lives on the floor.
But before we sign off, we want to leave you with a final provocative thought. Something that connects this highly specialized obstetric deep dive to the broader world of nursing. We've spent this entire time talking about surviving the pregnancy, getting the baby out safely, and stopping the maternal seizures. But the nursing care doesn't stop when the baby cries, and it doesn't end at the 6-week postpartum checkup.
This is a vital, often overlooked clinical connection. The severe vascular damage caused by preeclampsia and eclampsia, that systemic shredding of the endothelium, doesn't just magically erase itself once the placenta is gone. The blood vessels have a memory. Clients who experience these hypertensive disorders have a significantly measurably higher risk of developing cardiovascular disease, stroke, and chronic hypertension later in life. We're talking 2 to 5 times the normal risk of an early heart attack. The endothelial trauma leaves a lasting legacy on their cardiovascular system.
So here's the challenge for you, the future elite nurse. When you are discharging that new mother who survived severe preeclampsia, who endured the miserable magnesium drip, and who is finally holding her beautiful baby, how do you educate her? How do you seamlessly bridge your OB nursing knowledge with adult med-surg concepts? How do you empower her to understand that she needs to aggressively protect her heart, monitor her blood pressure, and maintain a relationship with a cardiologist for the next 40 years without terrifying her on what should be the happiest day of her life?
Because that is the true art of nursing, recognizing that the muddy diagnostic waters of obstetrics eventually flow into the lifelong stream of a patient's overall health. You aren't just delivering a baby, you are setting the trajectory for the mother's entire lifespan.
Exactly. From the microscopic failure of a construction crew in the spiral arteries to a lifelong journey of cardiac protection. Keep that big picture in mind. Good luck in your exams, trust the pathophysiology, trust your clinical judgment, and we'll see you on the next deep dive.